Okay, so today's lecture is going to be on peripheral artery disease. We finished talking about coronary artery disease, which remember are the arteries directly around the heart. So we do have lots of other arteries. So when we look down, peripheral artery disease will contain anything that has to do with the arteries not specifically wrapped around the heart. So aortic problems, as well as the arteries in our lower extremities, chronic ones, acute ones, etc. We are not going to talk about peripheral vascular disorders. Those are different. We're just talking about peripheral artery disorders. Okay, so the biggest one is aortic aneurysms. An aneurysm is any dilation or outpouching is the word they used here on a vessel wall is considered an aneurysm. So when we put it in the aorta, we call it an aortic aneurysm. You can have them on any vessel anywhere in the body can have an aneurysm. If it's in your brain, you call it a brain aneurysm. If it's in the aorta, we call it an aortic aneurysm. 3/4 of the aneurysms in the aorta happen in the abdominal section of it. Because remember, the aorta goes all the way from just above your pelvic region all the way up, to your heart. So if it's up in the upper section, we would call it a thoracic aneurysm. Down in the abdomen section, it's an abdominal aneurysm. So by looking here, you see this is a normal aneurysm, normal arteries, normal aorta. However, if we pouch out a piece of it, that is what we call an aortic aneurysm. So you can see down here, normal, and when it starts pouching out, that's when it's an aneurysm. The thing is, think about a balloon. If you stretch it out farther than it's meant to, it's much easier to burst. So that's our big concern with aortic aneurysms, is that they can rupture. And think about how much blood is flowing through our aorta at any given second, and you understand then why that is such a big problem. Because if it ruptures, you can bleed out very, very quickly. So that is why I say your size matters. Typically, these are found incidentally. Patients having a scan or a test for something else, and they will see the aneurysm in the belly. You can see this on a CT or on an ultrasound. You can see this pouching. Typically, if it is measured at under 3 centimeters, we call it noteworthy. That's one the surgeon or the vascular doctor is going to say, let's keep an eye on it. It apparently tolerates that 3 centimeter stretch. Okay. When you get up into 5 to 6 centimeters, then we look at surgery as a way of fixing this problem. However, we don't do it typically smaller than that because it's a very high-risk procedure. Think about it. If you're going to cut into someone's aorta, that comes with a high risk. So we don't surgically repair it until it starts getting to that size where it may rupture, which is around that 5 to 6 centimeters. So often these people are walking around asymptomatic while it's just in this area here. That's in that 3 centimeters, 4 centimeters area. They don't know they have it. But if we, even though we're asymptomatic, you can actually hear a bruit there. If you auscultated that part of their belly, you could hear the bruit. Once it starts getting even larger too, then we end up with abdominal or back pain. Even this, remember, not just from the front. You feel it in the back area. So if it is a TAA, which is a thoracic aneurysm, you'll feel that back pain up in between the scapula. An abdominal one, you'll feel back pain down in that lumbar area. Our biggest risk here is a rupture. Like I said, we can do surgery once it gets to that point where it's indicated. All right, so the difference between that and dissection. And this is hard to describe, so I have a video here. So bear with me. I think the screen's going to change a minute. This program is recording my screen. I want to pull up this video. Oh, man. Okay. Okay, so this is the video. I'm going to let this play for a second. All right, that is the aorta into the heart. And this is a normal, healthy looking aorta. And this is where our aorta comes into the heart here, or out of the heart, sorry. So out of the left atria, right atria up here, this is the ascending. Aorta is typically talked about, and you have it ascending. Up here where it bends is the aortic arch, and then we have descending. And obviously, this can happen anywhere. We look at the aorta. This is a normal vessel, so we have, this is the vessel wall, so the endothelium here, and inside lumen, so that's the tube. So imagine this is, if you cut across the vessel and look down on it, this is what you would see. So normally, blood comes out and goes out into the aorta, or here, you can see these are coronary arteries coming out. So some of the blood goes in the coronary arteries, and some of the blood goes out the aorta. So this would be normal flow. What happens if this right here is a tear in that inner layer of the aorta? Remember the picture a minute ago, there was a thing. So you end up with, some of it goes down the aorta. Some of it, however, slips into that little tear. So this tear doesn't go all the way to the outside. It goes between the lumen. So we get part of it, blood goes down here. Part of it goes in. So we have this kind of false lumen is what they call this, that creates this false lumen. So it's not really the true lumen, which is over here, the opening, versus this false one that just got. Think about the outside of the cell. Here we go. So the outside of the vessel wall got a tear in it, but it didn't go all the way through. So instead we have this vessel, this lumen here. So now some of the blood is going basically in between the layers. So if you imagine the two layers of this vessel are like a sandwich, and now I have blood going in between those two layers. So it's really not useful down there. In that space, it can't get where it needs to go. It can't do what it needs to do. It creates this false lumen there. That is a dissection. All right, and remember, you can go back and watch this video anytime you want, as long as you're in the slideshow version of PowerPoint. Pull it up and click on this word right here, and it'll carry you right back to that video. This has a very high mortality rate in an acute dissection. So if that little lumen creates itself, that false lumen, and starts taking on blood, it has a very, very high mortality rate. But it has other complications as well in the aorta. So cardiac tamponade is a separate disorder we can have. Aortic rupture obviously is a big one. And then the occlusion of blood supply to our vital organs. So in dissection, the big goal here is our blood pressure is actually, our goal blood pressure is going to be lower, because we don't want to have more pressure than we need on that aorta. Just remember that pouching has the vessel wall already stretched thinner than we need it to be. So an increased blood pressure increases our likelihood of a rupture. So our blood pressure goal is going to be lower. All right. So that was the aorta problems. The other part of peripheral artery disease are the rest of our arteries. So anything after the aorta. So this is where our aorta kind of splits, and now we have more arteries. So this is what, this is what supplies the lower part of our body with blood. This is our artery. Remember, arteries supply the oxygenated blood. The veins are what brings it back up. So this is, if I have a peripheral artery problem, I'm not getting blood to those lower, not oxygenated blood to those lower extremities. Primary cause, just like we talked about with coronary artery disease, is atherosclerosis. Same big cause. If you look on here, we see all these little yellow spots. that's the indicator for the plaques that can develop. So if I have all these plaques that develop, then obviously it's impeding my blood flow. So I don't get enough blood to those areas. You can also get peripheral artery disease from things like trauma or embolisms and such. But our main cause is atherosclerosis. So what are our risk factors for CAD? Smoking is the #1 risk factor for PAD. Hands down, the biggest risk factor is smoking. And I know I keep harping, kind of beating the dead horse here, talking about smoking. With hypertension, CAD, PAD, all of our vascular concerns, quit smoking is the biggest thing I can say. Hypertension is also a big risk factor for PAD, as well as diabetes, hyperlipidemia, as well as genetics. This is twice as common in Hispanic, Mexican, American women than in white women, and 2 to 3 times as common in blacks than as in white women. There is not, however, a big gender difference here. Similar prevalence between men and women. So what matters more than if you're male or female matters if you are Hispanic, black, or white. Those have a higher influence. And keep in mind, all these things are comorbids. So if I smoke and have high blood pressure and diabetes, I'm going to get PAD. So what does it look like? You can assess this a couple ways. Subjective. The problem here is we get symptoms after there's 75% of narrowing. So by the time we get symptoms, we've already blocked 75% of that artery flow. So that's unfortunate, right? When we have intermittent claudication, like early stages of this, so in earlier stages, we get intermittent claudication. Late stages, we get pain at rest. Aching, cramping, fatigue, weak painness, all the things you feel in the affected extremity. So this is not just an overall pain, it's pain in that affected extremity. Objectively, again, we're talking about the affected extremity, it will feel cool, pale, cyanotic if you elevate it. You can hear bruits, diminished pulses, all of these things. So if you think about it, if I'm not artery, if I can't get enough oxygenated blood to that area, if I elevate that leg, then it has to not only push, but it's pushing upstream. So that's why we don't like to elevate the legs in our peripheral artery disease patients. So one of the things that our body does, which is pretty cool, is it tries to fix itself. It tries to heal. So this is a normal artery. Blood flow is nice and free. Start getting these plaques that interrupt the flow. So now I don't get nearly as much blood flow through. So it starts to build these sideways paths, these alternate routes. It's kind of like taking a detour when there's a traffic jam. So the traffic's all backed up here, so I'm going to go off and take these pathways on the side. So it builds up what we call collateral circulation. It's providing another route for blood to get to that area that wouldn't be getting blood. The only downside to this, it's a fabulous idea and it's great, but think about it. The highway is super backed up, so you get off the highway to take an alternate route. You get where you needed to go, but you don't get there as quickly because now you've gone to smaller back roads that have lower speed limits, etc., so you don't travel as fast. So it's certainly better than nothing. Our body is trying very hard to make up for what it can't do. So this is a helpful tool here for assessment. So patients that have peripheral artery disease experiences 6 P's. Pain, extremity that's affected has pain, pallor, it can be pale, paresthesias, that kind of tingly feeling, pulselessness, paralysis, and poikilothermia. These are all signs of the 6 P's, we call them, for peripheral artery disease. Again, here's another video you can watch for assessment here if you want. It's very easy. What do we do for diagnostics? The bigger thing here is Doppler ultrasound will help show us the extent of the blockages. But the bigger thing is it's super easy. If we take a blood pressure on the arms and we take blood pressures in the legs, you will see a difference. Again, you don't have to do this. This is a diagnostic test the physician may use. The great thing is it's non-invasive, it's painless, not painless, but not painful, and it's non-invasive and very easy diagnostic tool. All right, when we start looking at acute treatments in PAD, a big determiner here is whether or not there's necrosis. So differentiating between the ulcers in the feet we'll look at on the next slide. So if there's no necrosis, so we have these ulcers that form on the lower extremities, and they're forming because we're not getting enough blood to them, but they look very different. So if we don't have necrosis, we can try thrombolytic therapies to break up blood clots and things along the legs, and may get Coumadin on the discharge too. If there is necrosis, we can't fix that. That's tissue that's dead. What we do is things to work around it. Can we do things like angioplasties and stents to help prevent more? FemPop and FemFem are referring to bypass. So if I know that it's where the vessel is, it's clotted, so we're not getting blood, we try to bypass it. Femoral being a femoral artery, pop being popliteal. So that's a very, very common procedure where they'll take a healthy popliteal vessel and move it to the femoral area, or vice versa. It depends on where the blockage is. But unfortunately, once we get to the area down there that's necrotic, they may end up with amputations. So differentiating between arterial and venous, we can look at here. Arterial, there's intermittent claudication, so we have pain, no edema. Remember, this is a problem of getting blood to the foot. There's no problem of getting it out, so that's why we don't have a lot of edema. However, if we're not getting good blood to it, you can have no pulses. If they get ulcers, they're round and smooth. And the sores and ulcers and the black eschar appear most common on the toes and the feet. On venous ones, so the venous stasis ulcers are what we typically call them, because the problem with venous ulcers means I'm not getting blood back up to the heart. It can't make its way back up, so it pulls down in the legs. So these are dull and achy pain. There's a lot of edema associated with them. You have pulses because the arteries are working, and that's what generates our pulse. So we have pulses. The sores here are the ones you've probably seen more often in your clinical experience. They're typically irregular borders. It's a slough, ruddy skin, and they much more drainage associated with those. Another type of peripheral artery disease is Buerger's disease. This is inflammatory. It's down, so we're fine in our big vessels. We get these in our small and medium-sized vessels. Then we still get this thrombi and this vasospasm, most common in legs and feet, most common in young men who smoke. At first, they get kind of a bluish cast to the toes and fingers. There's a lot of pain associated with it. They can develop ulcers and gangrene as common complications. Your goal here as nursing implications is relieving pain, doing frequent neurovascular checks, assessing their skin for ulcers, and you've got to emphasize quit smoking. All right, one more peripheral artery disease here is Raynaud's disease. This is localized. It's intermittent episodes. They get this vasoconstriction in the small arteries. So not so much blood clots and plaques and things. It's a vasoconstriction that happens. Very common in the hands. It can happen in the feet, but most often in the hands. Causes color and temperature changes. A friend of mine has this too, and when she gets these attacks with this intermittent episodes of constriction, the hands appear very pale, very white, or even blue. Usually it happens with exposure to cold or stress, and it's usually always bilateral. You won't have one hand that's blue and the other one that's not. And pallor, cyanosis, and rubor. Nursing implications here is teaching your patient to avoid the cold, like wearing gloves. So here this winter, when we've had degrees in the 20s, helping make sure your patient knows wear gloves. Avoiding stress. You can get analgesics for the pain, and we treat with vasodilators that help open up those vessels that had clamped down. usually with calcium channel blockers. And again, no smoking. These patients should also avoid caffeine and not use any drugs that have vasoconstrictive effects. We talked about angina before, and there was a relationship with this one and the Prince-Meadows angina, or the variant angina, which we said, remember, had to do with the spasming. So that's why this patient here has this vasoconstriction and intermittent spasm in their hands. They can also get it, if they get that same effect in a coronary artery, that's why they have Prince-Meadows angina. All right, PAD, key teaching, quit smoking. Very biggest one. Losing weight, low-fat diet. So this is, again, all of our coronary artery disease, just good in general health heart recommendations. So this is, like I said, helping with the vascular problems. When they are at rest, should elevate the feet. Don't leave them hanging down, but not above the heart, because we don't want to make the heart work any harder than it needs to get the blood down to the feet. We can keep them dependent to increase blood flow, especially for long term. Don't want them to have to stand for long periods of time. Remember, our heart is having a hard time getting blood down to the feet, so we don't want them standing for long periods of time. Avoid restricting clothing. Inspecting the feet daily is huge. As remember, once they get advanced disease here, they don't feel as well. They don't have as much feeling in their feet. As that starts to diminish, the concern here is if they have it's like a cut on their foot that they don't recognize it, and it's going to take longer to heal. So we want them to catch these things. They should be wearing shoes, not going out barefoot, because if they get an ulcer on their foot, it's not going to heal well at all, if ever. But we do want to encourage a walking program, and the physical therapist will talk with them too. What we want is that collateral circulation we were talking about. We want that to develop. So what happens is when they get walking, encourages that blood flow, and that's what promotes the growth of that collateral circulation. So teach them to walk to the point of pain and stop. We don't want them to stop before it starts hurting, because once it starts to hurt, that is when it's reached that point, and it will start generating that collateral circulation. So tell them to walk up to that point, and then they can stop. But we need them to get to that point to help promote that collateral circulation to grow. All right, so we're going to leave Ben, and we're going to hang out with Dean for a little bit. He comes into the ED. He's complaining of progressive left leg and foot pain. So we look at his history. We see he's been a 2-pack per day smoker for 50 years. He's 220 pounds, a lot of cardiac history already. CABG, coronary artery bypass graft, hypertension, PAD. He also has respiratory problems, COPD. Go figure, he's still smoking. A lot of family history too, emphysema, hypertension, diabetes. A lot of family history here as well. So, again, I can't ask you guys questions through this presentation, but look at what you notice. And this is an ulcer on his foot, and so how would you expect it? What are we looking as for here? And again, not an excellent picture, but you can see here, I don't see a lot of edema, I don't see a lot of oozing. It's nice regular edges to it. So all of the things for arterial ulcer. All right. So for diagnosis, do a Doppler ultrasound. We found significant disease in the left femoral artery. So the physician orders a heparin bolus followed by a drip. Very, very typical dosing for heparin. You start out with a bolus and follow it with a drip. It is almost always in a standard mix in the Pyxis. So like here, 25,000 units, it comes in a 250 ml bag. And we will practice some of the heparin drip questions and recitation. So here you would need to calculate how many mLs you should do. Whatever method you use, for math, use it here. Just because the numbers are bigger doesn't change the method, okay? Just use your usual method, whatever works for you, be it formulas, be it the dimensional analysis, whichever one works for you. So you can always break this down to 100 units per ml is what's supplied. And that gets you down to easier to manage numbers if you don't like working with the 25,000 units, okay? Oh, in case you missed it, if you're not looking at this presentation separately, the answers are in the notes. The bolus would be 6,500 units. The IV rate would be 13 mLs an hour. All right, so this is where we see that he is admitted to the surgical unit, a non-necrotic PAD. In other words, there's no necrosis down there on that wound we looked at. But this shows you here, he's scheduled for a fem-pop bypass is what we call it. So femoral artery here, bypass. We're going to take a good vessel and graft around that from the femoral down here to the popliteal. We're going to bypass the blocked area. Very, very, very common site of blockage right there too. So priority nursing diagnoses for him, you can probably think of many here. Pain's going to be one of them. Skin integrity is a huge one here for that ulcer he already has on his foot. So you're going to have nursing interventions and care around his skin care, around his pain level, etc. So ineffective tissue perfusion, right? So your interventions here, assess those P's, record them, assess them and record pulse strengths, pain, pallor, anything he's feeling, all right? Teaching. I don't care how long he's been smoking, we still want to teach about smoking cessation, hands down. Keeping this extremity in a neutral position and doing frequent position changes so that we can keep our skin integrity intact too. Exercise, like I said, to build that collateral circulation. And then he had a lot of other comorbids in his history, so we still want to control those. Don't just focus here on the PAD. Make sure we're controlling everything. All right, so medications, he is probably going to be on the IV heparin. He may switch to sub-Q Lovenox, so you need to be monitoring for bleeding. PO Coumadin, if there's no clot, we'll monitor per PTINR. Aspirin every day. Trintol actually decreases blood viscosity and increases the blood flow too. And Pledol, I don't know if I say that right, inhibits platelet aggregation, so we get more vasodilation. So some other potential diagnoses here, like I said, acute or chronic pain. Probably may have both. He may have chronic pain and is now also experiencing an acute episode of pain as well. And impaired skin integrity is going to be huge with these patients. So post-op, he is recovering. He recognizing smoking cessation is a priority. So think about to yourself, where would you take someone who's been smoking so much for so long, and what tools and things you might use to help him quit. All right, so this, guys, we will go over some of them out and stuff in recitation as well. So thanks for listening, and I can't wait to see you guys in class.